morning, morning, morning. Good morning. Good morning to you.
I want to say good morning to Dr. Wanda Bellamy. Yes, she's a urologist at the QEH, and she is the first woman in that field. So with that alone, she's automatically my friend. Good morning to you.
Good morning. How are you doing?
I am great. Urology. It's a specialty that for years Barbados has had only a few names that you hear of. People study medicine, they want to go automatically to pediatrics. A lot of young doctors are now getting into the world of aesthetics. But what made you want to do urology?
Okay. When I came through medical school and I reached the wards, the clinical part of medical school, I realized that I loved surgical procedures. I didn't know quite yet that it was surgery, but procedures. I even liked pediatrics, or thought I did. But I realized I liked doing the procedures in the neonatal ICU. So when it came to choosing a career, surgery was number one. And then as I rotated through surgery, I realized that urology was a niche on its own, where we had our own patient set, basically, the majority men, but some women. And the pathology within urology is very interesting and limited to a certain set, just the genitourinary tract. And that makes it very unique. It's interesting, and innovation and technology has really, really spun off over the years. So there's so much to learn, and there's so much progress that has been made. So it's exciting.
Okay, and you actually sound excited in terms of describing it.
Yeah, I am.
You know, kind of thing. And I'm thinking, who wants to be around the bladder? Who wants to be around kidneys? And that's the other thing too, because when we think urology, we only think about dialysis, we think about a urinary tract infection, but I'm sure the world of urology is a lot more than that.
It definitely is, and actually dialysis is more the medical aspect of kidney disease. That's not urology at all. That's nephrology. We deal with surgical problems, either problems that can be rectified with surgery or have some kind of anatomical issue. The patient has an anatomical problem, obstruction that can potentially be repaired by surgery. Whereas the medical aspect, when there's a medical problem with the kidney, you kind of have to tend towards dialysis. You have to replace the kidney with dialysis. Urologists, if you do that aspect, would replace the kidney by transplanting the kidney. So that's the difference,
okay,
you see?
Between the two.
Yeah.
Okay, interesting. Now, in terms of doing procedures and so on, you never had any level of squeamishness? Because there's some people who are doctors, but they would tell you, I don't want to open anyone up. No,
definitely not. Maybe my first day reaching the wards as a student, you know, the curtains were closed and I thought about what I was going to see behind the curtain, and it freaked me out for that one time. But after that, not a problem. But it's very different when you're in the operating room. You make the wound, you make the incision, you look at the anatomy, you dissect. It's so gratifying. It's it's a really good feeling to do surgery, actually. Okay. It makes our week. We can get through the clinic and the ER and all of that with one surgery day. It makes up for all of that.
So that's where you prefer to be?
Definitely.
Definitely.
The OR is what it's all about.
So how do you feel knowing that the profession, this particular specialty, is so male dominant? And was it hard for you to have to fight for your position in that space?
I feel good that I am the first female urologist in Barbados. I'm not the first female urologist in the Caribbean. There are others, a few others, who have gone ahead of me, and we stick together as females in urology. It wasn't hard, I would say, to get into the program or get through, to qualify, if you understand what I mean. Obviously, it also depends on the patient's outlook. Are you happy to come to a female urologist? It's a new thing for most men.
But that's what I was going to ask. If they don't have apprehensions that you know, somebody's going to be, a woman is going to be the one to determine if those things continue to work correctly thereafter.
Right. So I infrequently get a patient who would prefer, or who seems to prefer, they may not tell me, to speak to a male colleague. Very infrequently. And it's probably down to the choice. They don't have many choices. But that's because I'm in the public system as well. I probably would have to see how it goes in the private system.
Okay.
However, what I do find is that when, if I communicate with them well and they understand what I'm telling them about their health, it's not a problem. They actually open up and they're able to express how they feel about their health. So initially they may be uncomfortable, but I find that they do settle down.
Okay.
Yeah.
So in terms of the health concerns and prostate and all these other things, what are some of the things that you tend to favor in terms of the procedures you do? And do you prefer operating more on males or females?
Definitely males. I do like male pathology more so. I love to do prostate surgeries, whether it's for an enlarged prostate or prostate cancer. The two operations are different, but it's a lot of dissection and intricate details about the surgery that make it very interesting. I do like kidney surgery as well. In fact, I like every surgery.
Okay.
But urologists
you like that scalpel.
I do. But urologists do a lot of surgeries that don't involve a scalpel, actually. So they're open procedures, which are very good. But then we do a lot of endoscopic work. So a lot of camera work with small cameras going through the urine passage and actually either resecting or scraping the prostate that way, doing bladder tumors that way. We do laser surgeries. So the range, you know, we go from fully open to fully endoscopic, where the patient doesn't even have an incision. Okay. And that's the beauty of it as well.
So you love the technology and all the advances it's been making.
Yes. Even stone surgery has progressed from open all the way to, simply putting it, a puncture surgery, which would be a PCNL, or even just shock wave, where you have no incision at all, no camera. It's all external.
Shock wave, because that sounds as though some sort of vibration is going to be against the area to try to dissolve that stone.
Pretty much.
Oh, so okay. So I'm bang on then.
So the stone is inside your kidney, but you lie on a bed, pretty much sandwiched between a machine that is sending shock waves, that's sending waves to actually destroy the stone. So the waves reach the stone. It's like sound waves, basically. Okay. Nothing is seen. Well, something is heard, certainly, and that shatters the stone inside you. So that, you know, that technology is really good. It's not for every stone, but certainly is a good option for patients who qualify for that kind of treatment, because they don't have an incision. They don't have to have, you know, in an invasive procedure.
And I've heard people talk about kidney stones and how painful it can be and that kind of thing. I've never experienced it, but I've heard that the pain can be severe. So I'm sure moving from somebody who's on that bed screaming to a situation where you get to visit and see a much calmer individual must be really gratifying.
Definitely, definitely. And stone pain is one of the worst pains known to man, you know. I suppose labor pains as well, but at least with labor pains you get a nice baby to cuddle.
I don't think we want to see the stone thereafter, right?
Exactly.
What about when it comes to having to operate on children with any kind of urological issue? I know sometimes, like for example, as a mother, I know sometimes little boys can get into all kinds of dangers and get repeated bladder infections and different things. And some of them actually end up with blockages, you know, and you might have to correct those. How is it dealing with the little ones?
So I don't do a lot of pediatric urology. Pediatric urology is, yes, a subspecialty of urology, but it is so special and so different from adult urology that doctors who train as pediatric urologists tend to only do pediatric. They tend to, you know, unless you're in a setting like, say, Barbados, where we kind of have to be all-rounders to some extent. If you practice pediatric urology, That's pretty much all you do, because the range of disease is so far from what you see in adults. Children don't have prostate problems.
Yes.
You know, really what they may have is a ureteric problem, a reflux problem that leads to a kidney problem, or a whole bladder issue that you have to do a lot of reconstruction for, or they're born with their, the tip of the penis where the urine comes out, that may be in a different location, opening a little further up and not at the tip.
Oh.
And that requires years of reconstruction to get it to be more normal, you know, and get them to be able to stand and urinate in a normal way. So it is an involved field, and you have to be really committed to that, because if you meet that patient at age, you know, at birth, you will continue to follow that patient for the most part for the rest of their life if you're doing that kind of reconstructive surgery. So you see, so it's quite committed. Yeah, but I mean, we can, you know, I can handle the circumcisions, the simple surgeries of a child.
Yeah, circumcision.
That child needs.
And of course, it's best at birth, because some people thereafter have issues. They get, even the mothers get all squeamish having to deal with it as the child is older. Now, in terms of
I tend to disagree.
You do?
Yes, I think that we can all try to stretch the foreskin every day, about twice a day at baths, once during that first year of life.
First of all, you have to convince little boys to take a bath. And this is coming from a boy mom. You have to convince them to do that. Furthermore, to have to be stretching. And they're like, no, it's going to be painful.
So I'm a boy mom. So
exactly.
I am advocating that you do it in the first year of life when they have they can't argue back.
Precisely. Right? The earlier the better.
The earlier the better, and you may actually you usually will avoid the circumcision.
Yeah, the earlier the better. Now, in terms of the services provided, what are the range of services currently at the QEH that you can offer to your patients?
Okay. So, starting from the kidney, just anatomically, the kidney, the ureter, the bladder, the prostate, the penis, the scrotum, the testicles. We can offer surgeries on all those organs in terms of stone disease, tumors and malignancies, prostate enlargement, bladder stones, urinary obstruction. You know, we can manage pretty much all of those. What limits us in Barbados at the moment is some of the more modern equipment. Not in Barbados, I should say, in the public sector, where you would have heard me maybe mention in my last interview, we don't have lasers yet. So we can't do laser surgery, laser prostates, but it doesn't mean we can't manage stones and prostate. Yeah. So we manage most things in an open surgical way. But once we get that laser, or once we get more equipment, we'll be able to do more endoscopic work. You know.
What about women who may present with major bladder issues, say after complications from childbirth, stuff like that, repairing incontinence in women? Do you do that work too? So
again, another involved urological specialty. So I don't have that much experience, but certainly I do know in that field, that's reconstruction. But yes, we can repair bladders, we can do some extent of it, but sometimes women with incontinence need slings placed. That can be done. And if it is that we can't, or we don't feel confident that we have the experience to do it, we can always find the path by which they can get it placed.
Okay, so in terms of referrals, whether it be to somebody else in the region,
we know
what have you, or bringing people in. Yeah. Okay, so you mentioned that you too are a boy mom. How do you juggle the two?
I don't know. Sometimes I feel like a headless chicken, running here, running there. However, I once watched a world leader, a female world leader who was obviously a mother, a leader, everything. She said, every day something has to give, honestly. So one day it's going to be, I'm in the OR and that's my focus for the entire day. And the children will be picked up at 4 o'clock, and then I will focus on them. But I can't do it all at the same time in one day. But
Understood.
generally, it's 24 hours of constant going until I
Well, let me
rest
tell
my
you,
head.
you're going and you're still looking well for doing it.
Well,
So,
thank God.
Yes, so nothing has been lost. I want to thank you so much, Dr. Wanda Bellamy, for coming and continue to do the work. I hope you get all the equipment needed so that we can continue in this field and be as top-notch as I can see you're determined to be. Thanks so much for coming.
Thank you so much.
Morning, morning,